You have another video where it talks mostly about pediatric testing. In this video, we're going to touch on infant and toddler testing because there are some major differences in those. For infants, we can measure lung volumes. We can use plethysmography or gas dilution. We can also measure compliance and airway resistance, and we use a passive method for that. And then there are some other methods that you can just get compliance, but we're not going to talk about those in this video. They are in your book if you are interested in following up with those. Infant testing, we use this to measure the growth of the lungs, identify airflow obstruction, monitor progression of diseases, and monitor response to therapeutic interventions. To do this, most of the testing is going to be passive, meaning the patient's going to be asleep, relaxed, and spontaneously breathing. And we are either going to be measuring flows or volumes, and we're going to sometimes occlude the airflow to the patient and then release it. Another thing we might do is compress their thorax in order to measure their vital capacity. But all of infant testing is going to be passive. So in order to do that, our patient needs to be sedated. The respiratory measurements made during sedated sleep then are going to be influenced if that sleep state is altered. So if we get them too sedated and it affects their breathing, then that's going to affect our testing results. So part of our job is going to be to recommend or select one of the most appropriate sedations. The best one for infants is chloral hydrate. It's orally given, does not require the use of an entire sedation team, so you don't have to have the anesthesiologist and whatnot. Unfortunately, the baby has to consume a large quantity of unpleasant medicine, and it can cause vomiting. However, the good thing about it is the respiratory pattern is normal. It's not affected by the sedation. In contrast to that, some of the IV medications listed in front of you can affect their respiratory pattern, and they are going to require the full sedation team. So when we perform lung volume measurements on infants, we need them sedated, we need them in the supine position. We're going to have a tight-fitting mask with putty around the edges. You can see it here, it's like pink. And then we want a very small dead space volume in the mask. It is important to know that face masks can cause trigeminal nerve stimulation and induce vagal reflexes that may alter the pattern of their heart rate and rhythm or their respiratory frequency and pattern. So monitoring your patient for these changes is going to be part of the expectation during the testing. So plethysmography, as you saw in the last picture, I'll go back, see this is the plethysmograph, okay? It's a little tiny box that a baby can fit in. And what this machine is then going to do is, with the mask on the patient, there's going to be valves in the machine that make the airway occlusions at end inspiration or end expiration. And then the machine will be able to determine the VTG in airway resistance. Obviously, we can't instruct the infant to pant, so what happens is we have to have very precise and accurate pressure transducers and flow sensors that are going to capture this information as those valves open and close. Along with this, we have to maintain the temperature in the box and make sure it's air vented. The advantages of plethysmography is that it gets an accurate measurement of the VTG, which we can then determine the FRC. So that is all passive. Another thing that some plethysmographs can do, not all, is if they can do a raised volume forced thoracic compression. What this is they increase the volume in the patient's lungs by delivering pressure into the mask, and then they have a bladder or like a vest around the patient's thorax, and it then compresses the thorax, and then the device is monitoring the expiratory flow rates and the volumes captured, and so we can get pretty close to a vital capacity measurement as well as obtaining other flow rates and other lung volumes. Not all systems can do that though. Okay, well, So when we get to the toddlers, though, they're going to be too big for the plethysmograph. So we need to come up with a different method. That single breath passive measurement of compliance is not feasible. The chloral hydrate is no longer an option for sedation. So then we have to move to the ketamine or propofol. So now we're increasing our risks. So really, with toddlers, we probably want to have them awake and cooperative and try to work through lung volume testing as we would an older child. Another reason we can't do passive measurement with toddlers is because their chest becomes more rigid and they lose the Herring-Brauer reflex, which we use, which is needed to do the passive testing with infants. So, gas dilution measurement of lung volumes can be used in infants as well as toddlers. The different gas methods are helium dilution, nitrogen washout, and SF6. The disadvantages are that infants will still require sedation. Any fussiness or movement can cause leaks, and that could falsely elevate your FRC results. The advantages is ages 3 to 4 years old may tolerate sitting in a chair, using a mouthpiece, nose clips, or a mask, and might be able to perform the test just fine. Some of the causes for false high, as I mentioned, are leaks caused by fussiness or movements, and then also hypoxia. The reason hypoxia can cause this is because the child is going to try to compensate for the hypoxia, so they might start grunting or breathing deeper, and so it's going to change their FRC because it's dynamic, because they're using their muscles more. Then you can also have a false low, and this is if there is airflow obstruction, so maybe there's a mucus plug or something, and the gas is not going to be able to wash out distal to that obstruction. Or if they're in super deep sedation, they're going to breathe more shallow. Now, an important note about getting your FRC and your lung volumes, when you start evaluating your flow rates and you've obtained your FRC through this method, when you describe one of those parameters or when you report it, you're going to want to report it as specific. So saying it's specific means that it's referenced to the FRC obtained through the gas dilution technique. So, for example, maybe you're reporting on compliance. You're going to call it specific compliance when you're referencing it to the gas dilution FRC. Okay, going on to passive measurements. Again, keep in mind, when we're passively getting measurements, we have that mask on the patient's face, they're breathing, and we're just gathering the data. The machine is occluding parts of the airway on inspiration or expiration and gathering those results. Another thing we can use is the motion of the thorax and abdomen, and we can use what's called respiratory inductance plethysmography, also called respiratory belts, and basically the expansion and retraction of the chest can create a virtual flow volume loop in order to measure respiratory mechanics. Now, with preschool and older kids, we can use some different techniques. The impulse oscillometry, interrupter technique, and exhaled nitric oxide are all options. Now, I'm not going to go into super detail here, but I did want to talk about this Herring-Brauer reflex. Now, where it comes into play is where we're using the passive occlusion technique in order to measure compliance and airway resistance. So what happens with this test is that during a single breath, the airway is occluded in the machine, okay? During that time, the alveolar pressure is going to equalize, and then it can be measured with a pressure transducer at the airway opening or the mouth. Now, what happens is when during this test, when the occlusion occurs, the baby's response, the infant's response, is to hold their breath. And this delay where they hold their breath gives time for this pressurization, this alveolar pressure equalization to occur. Now, that's once kids lose this reflex, or if they have severe lung disease, their respiratory drive is so strong that they don't have this reflex, then this test will not work. Okay, but through this test, they can obtain compliance measurements as well as airway resistance measurements. Important to know is the repeatability of this. You need to use a mean of at least 10 consecutive breaths or 30 seconds. And then that's going to be what you're going to compare your measured results to. That'll be your baseline. Just a few notes on that. Okay. The respiratory belt analysis. This is truly non-invasive. There's no mask, although this picture shows it. What I'm talking about are these two belts right here. There is no device at the mouth. Typically, you're going to see this used in a sleep lab. Rarely is it used in a PFT lab because it's so non-invasive, actually. Again, it's called respiratory inductance plethysmography. And so you're going to measure the motion of the patient breathing. So when they take a breath in, you see it move up. When they exhale, you see it move down. And they can monitor their respiratory mechanics through that. One last thing I want to touch on before our time is up is the tracing of their flow volume graphs. So here, letter A is a normal graph, and you can see the slope of the curve is linear, okay, right here. Oops, I need to move the whole picture. Right here, it's linear, as opposed to someone with airway obstruction. See how it is curved. It is not linear. The time constant is the amount of time to expire, should be approximately 2/3 of the tidal volume. The time constant is easily calculated as compliance times resistance, and then corrected compliance should be recorded using the specific compliance term. Over here, as I mentioned, you see that the slope is not linear. The expiration could be forced with some paradoxical movement of the diaphragm and belly. The accuracy of compliance and airway resistance measurements made under these conditions is going to be poor because of that. The exhaled curve may end abruptly with the child at an elevated FRC or may appear scooped out. The lungs do not empty homogeneously or uniformly and therefore have multiple time constants. So over here. So I just wanted to touch on the difference of what those flow volume curves are going to look like and how you can tell a normal versus an abnormal result.